Welcome, everybody. I would like to, before we get going, a lot of the work that Collaborative does is done by Sally Plever and Irene McCarthy. They're on, so please feel free if there are any really difficult questions to ask them. Now, moving to the first slide. Thanks, Carla. Okay, I think I'm speaking to the converted here, but mental illness and mortality, there is overwhelming evidence of the situation our patients find themselves in. There's a life expectancy gap up to 25 years. It's probably worse than what the Indigenous community face. All our patients, particularly those with chronic mental illness, smoke, they're obese, they've got high blood pressure, they usually have diabetes, there's poor nutrition, and there's a sedentary lifestyle. We know that it goes underdiagnosed and it is certainly undertreated by our staff. And certainly the medications we use, contribute to this situation. Next slide. If we look at the physical health of the average Queenslander, the average Queenslander dies at about the age of 80. The leading causes of death are coronary heart disease and lung cancer. 77% of people have at least one long-term, medical condition. 66% of the population are obese. 21% have hypertension. 5% have a high cholesterol, and 12% of our adults are inactive. If we have a look at some of the figures relating to our population that we deal with every day. Next slide, please. As you can see here, in terms of wastes, 77% of males and 91% of females have a girth greater than is regarded as helpful. BMI, 76% of males and 74% of females have that. And this compares to 66%, which we saw in the last slide. 50% of our population have a raised glucose in males and 47% in females. Our next slide, please. And so the long-term issue for us, and as I've said earlier, the Mental Health Collaborative has been focusing on metabolic monitoring, particularly in people with chronic mental illnesses like schizophrenia since about 2012. The two aims of the collaborative have been over that time. One is to embed a physical health assessment as routine psychiatric practice at a minimum of every 6 months. And when we find something, do something about it. Next slide, please. Now, this just shows the how we went over the years from when we started in January to June 2012. There was at that stage there was evidence that about 12% of our patients were getting metabolically monitored. By the time we moved on to smoking, which was December 2018, almost 70% of people were getting some form of metabolic monitoring, which is quite good. And if we want to look at this a different way, this is another one of Sally's brilliant slides. Next slide, please. So when we started, 1 out of 10 had a physical assessment. 6 years later, almost 70% of people were getting a physical assessment. As has happened previously, the Mental Health Collaborative is no longer producing data. The branch have taken this on, and it is now one of the performance indicators for all community mental health services. And it's been broadened not just for people with chronic schizophrenia. It's now a requirement for all patients. So I think the state is now doing reasonably well. I'd say reasonably well. It could still be a lot better in terms of the monitoring. The sad part, and we'll move to the next slide, is if you actually have a look, and we've done audits here in Metro North a number of times, you'll have people with BMIs of 30 or 40. They'll have a history of smoking. And when you go through their clinical files, there is no evidence that either the mental health clinician that they're linked to or the treating psychiatrist or registrars are doing anything about it. And so I'd like to spend a couple of minutes and have a discussion about what we actually need to do. This next slide deals with, sorry, just the slide that's up there. It shows that, and this is for all patients, somewhere between about 24 and 39% of people, there's evidence of some sort of physical intervention, and the range is from 14 to 68%.
I thought I'd start with a patient who sticks in my mind. He was admitted about 10 years ago, almost exactly, and the results start on the right and move across in time. So the most recent is on the left. And what we can see from the biochemistry here is just the renal function typically, but we can see at the top icteric. So the supernatant, the serum is bright yellow orange. This patient was admitted with anorexia, nausea, and abdominal pain. And if we just go down to the liver function, you can see the ALT is grossly elevated, AST less so. The bilirubin, which is causing the icterus, is also markedly raised. So this chap had some tests while he was in hospital. He showed reactive to hepatitis C. 12 months before, his hep C test had been non-reactive. He did not have any evidence of hep A or hep B. So this looks to be a likely diagnosis of acute hepatitis C. The way we would verify that, and one of the take-home messages from today's talk, is that we really need the RNA to confirm that this is indeed the cause of his illness. There would still be some other possibilities, and the hep C could be an inactive problem in the background. So I'm principally going to focus on hep C because I think it's fair to say in the case of hep B, our job really is to make sure patients are vaccinated. Anyone at risk in particular, someone who might be injecting drugs, they are entitled to free hep B vaccine. So that's something we should certainly attend to. And I think it's now part of the childhood vaccination protocol. So it's really adults who may have missed out, who may be at risk. And one course, one documented course is good enough, even if the antibodies don't persist. That still allows your T cells to remember hep B from long ago and respond appropriately. So on the left here, I've recorded the risk factors for hepatitis C. And hepatitis C largely is explained by injection drug use. So 80% of the total cases and 90% of new infections appear to come from injection drug use, so shared needles, paraphernalia, and indeed environments. The gay community is at risk of hepatitis C. Imprisonment, sometimes prisons are described as an incubator for hep C because the lack of availability of clean injection equipment and the widespread use of needles shared between prisoners. Some migrants are at risk. So in Egypt, there was a campaign to eliminate schistosomiasis, which involved reusing needles on kids multiple times. And that led to an extraordinarily high prevalence of hep C in that community. Tattoos, one would hope that's a thing of the past, but dodgy tattoos, for example, those done in prison, would certainly be a risk. Hep C was only really characterized properly in the late 80s, only around 1990. So anyone who had a blood transfusion before that may be at risk. Interestingly, in the States, the CDC advises all boomers, so that post-war generation, to be screened for hep C. So no risk factor, just screening, because the boomers account for 75% of cases in the US of A. Worldwide, there are about 71 million people infected with hep C, which is about 1% of the global population. So in Australia, we now have about just under 130,000 individuals who are infected. And there were 9,000 new cases recorded in 2016. So we've got a dynamic here. We've got effective treatment, which I shall discuss in a little more detail. We've also got new cases occurring. With the arrival of the direct-acting agents in 2016, in March, 73,000 patients have been treated. So a huge number have been treated. The the worrying thing, though, is that the numbers being treated now have fallen off dramatically. So what happens in Hep C? Well, we know that after 20 to 30 years, about 30% of patients will develop cirrhosis. If they're also using alcohol heavily, then that will greatly accelerate the process. Likewise, obesity, to go back to the metabolic monitoring. So if you're a drinker and you're overweight or obese and you have Hep C, that kind of accelerates your likelihood of early development of cirrhosis up to 9-fold. It's really dramatic. In patients with cirrhosis, there is an ongoing risk of hepatocellular carcinoma, HCC. So 2 to 3% develop HCC each year. And that's why in patients with advanced fibrosis and cirrhosis, there is an ongoing surveillance program with 6-monthly ultrasounds. One of my colleagues from Prince Charles Hospital, he'd had Hep C for many years. Treatment was ineffective in those days. He'd gone through it without success. And he was having the regular ultrasounds, but unfortunately, the lesion was not picked up. So he died, sadly, from HCC about 10 years ago now. And in our clinics, at least 5 patients in their 50s and 60s have died from liver failure and or hepatocellular carcinoma with underlying hepatitis C and often alcohol as a co-factor. So there's a big move worldwide to eliminate Hep C. And this report, which was commissioned by Gilead, no coincidence there, I suppose they make one of the leading medications, the direct-acting agents, Epclusa and Sovaldi, the 2 out of 3, which are pan-genotypic. They treat all 6 Hep C genotypes. So they've commissioned this report, which looks at different countries. And it's good to say that Australia is one of the leaders, and according to the report, it's still on target to achieve the WHO goals of a 90% reduction in incidence, 90% rate of diagnosis of individuals, 80% of eligible population being treated, and 2/3 reduction in liver-related deaths. And that's by 2030. So John sent me this article, and it shows very nicely the kind of way in which you fall off in numbers from the initial finding of an antibody to Hep C. As you can see there on the left, this is a population of inpatients identified from the IEMR. So 3.8% of these inpatients, and it was many thousands, 9,300, there you can see, they showed an antibody positive. Now that means that sometime in the past they've had hepatitis C exposure. A proportion of those went on to have the hepatitis C RNA, so that's about 90%. And from that, about 60% showed an RNA positivity. In other words, they have ongoing hepatitis C, chronic hepatitis C. Only a proportion of those, 86%, were referred for care. A quarter didn't show up for their appointment. And then only just over half had treatment written up. And then only 40% had treatment actually started. And then finally, 1/3 of them were treated. So we had 311 patients with a positive RNA test, but only 42 landed up getting treatment and successful elimination of Hep C. So if this is what's happening in a civilized country with an electronic health record, we've got a long way to go, haven't we? So this is a report from the Kirby Institute, Australia's progress towards Hep C elimination. In the early days of the direct-acting agents, there was a suggestion that really the evidence to support their use was not yet available and we shouldn't embrace them too warmly. There was a suggestion that they could, A, activate unrecognized hepatitis B, so we have to exclude hepatitis B before we start Hep C treatment, and B, that they might activate underlying hepatocellular carcinoma, for example. Now, what's happened in the 4 years since the agents really became widely used? You can see on the left here, we've had a reduction, significant reduction in decompensated cirrhosis, in HCC, that's flattened off, in liver-related mortality. So it's gone the opposite way of what might have been predicted. And likewise, all-cause mortality has slowed down significantly. So the direct-acting agents are saving lives. They really are effective. And those early critics, I think they've been proved wrong. Now, this just shows how the prescribing rate has dropped off. So in 2016, it was actually March 2016 when the DAAs became available on the PBS. There were 32,000 patients treated. A lot had been put on the shelf until these agents came along, so they may have waited several years. But it was worth it because these agents give 97% roughly success rate in eliminating Hep C and therefore curing people of infection. The old treatments, even with the changes that were made, were rarely more than 50% effective, with horrific side effects in many cases. So what we can see here is a steady taper in the number of patients coming into treatment. So last year, there was only about a third of those who'd been treated in 2016, and partly COVID related. It looks like the total for 2020 is going to be only about 7,500. This was an editorial in the New England Journal, and it compared 3 countries. And anyone who wants to look this up, it was published in August and makes good reading. And one of the chief author was Greg Dorr. Jason Greebley, who's a colleague in Sydney, he helped Greg put the paper together, but the New England said they could only have 2 authors, so he didn't get his name on. But I put this on because it shows that really our treatments are dramatically good these days, regardless of your cirrhotic status, your underlying liver disease, et cetera, whether you're on opioid treatment or not. And you're also going to get excellent results in whatever treatment setting, principally in general practice these days. That's the majority of cases. On the left here, we've got the numbers infected, and I just highlighted this down the bottom. The prevalence as measured in needle syringe programs where they do finger prick testing has dropped down from 51% to 18%. So we are really making a difference, but there's still a way to go. So these are some of the highlights, the real goals that help countries on their way to elimination or achieving the WHO goals by 2030. And I've really starred the ones that seem to me most active in Australia. So rapid antibody screening and a single reflex viral load test. We don't actually do viral load tests, but what we are anymore, because they're not required by PBS for prescribing. But what we are doing is having point of care testing. So you can get an answer in an hour or so, and there's a good chance that the machines involved, which measure Hep C RNA, will be rolled out across major centres in coming months. And that will really help target the hard to reach patients, because they're the ones that we're trying to get into treatment as things stand. So pan-genotypic direct-acting agents, yes, we're certainly using those in Australia. Trying to coordinate with prisons. So there's a nurse practitioner in the southeast corner prisons whose sole job it is to try and get people into and onto hepatitis C treatment. And I learned the other day that when someone is released from jail, they're actually given their entire course of remaining treatment, so they don't have to re-engage with a health provider and get it prescribed again. Innovative solutions, one of the innovative solutions featured in that report sponsored by Gilead was the Combi Clinic, which you may have heard of. That's 2 enterprising GPs from Inala, Joss Sloan and his colleague, who take their Combi van around and about and offer fibroscans and blood testing and treatment for patients who might not come and visit conventional health service settings. Training and communication for healthcare staff. We're certainly trying to do that, and maybe today is one more example of that. So needle syringe programs, they're an important part, though only one part of the response. And as you can see, numbers being provided, particularly from the public NSPs, have been growing steadily each year. And I talked to Robert Kemp the other day. He suggests that it may be the case that Biala is the busiest needle syringe program in the world, not just in the Southern Hemisphere, as we used to say, with 2 million fits or so issued each year. And if we go back to that earlier slide, there's a needle syringe is distributed per person who injects drugs per year. So 461 fits per person per year, in contrast to the US, where in some states it's illegal to have clean injection equipment, just 30 per year. Is it any wonder that they've got such huge problems? So this is my final slide. Thank you for listening. We've got updated guidelines for Hep C virus infection. It is really very easy. Forget about the complexities of SSRIs or antipsychotics. This is dead easy. All we need to know is, does the patient have Hep C antibodies? If so, we need to get their Hep C RNA. We no longer need the genotype for PBS, though for some it's a matter of interest. We should probably know their liver tests, their platelet count, their full blood count, maybe their clotting. And if there's any doubt, we can check their liver for fibrosis using the FibroScan. That was invented to test the ripeness of cheese for export from France, but it's come to a new life as a way of looking for the stiffness of the liver in patients with scarring, fibrosis and cirrhosis. We now have three pan-genotypic regimes, which are 97% or more effective. I had two patients who took their first month's treatment of a 3-month course of Epclusa, Sofvel, and then they didn't have any money to get the next 2 months. So what a mess, I figured. Nevertheless, we were able to persuade them to get their RNA done at 3 months, and both had happily cleared the virus. Now, that is not recommended, but it shows the regime is pretty effective and quite tolerant of incomplete concordance. You don't need to do any monitoring of bloods. In the old days, they were checking levels and LFTs and platelets and hemoglobin every 2 weeks. And for many of our patients who have very poor venous access, this is a real hurdle, real obstacle to coming into treatment. And really, you just want your 12-week post-treatment RNA. That means you can tell the patient they're cured. Now, there's some discussion whether that's really needed, because that 97% efficacy is such a high level. There's very few treatments in medicine which are as effective as this. A nurse practitioner can prescribe, so we've heard one working in the prisons, and we have one, a Biola Tim, who prescribes Hep C treatment, usually in consultation with one of us. There's now been a change to the PI, which means under 18s can be treated. There is a risk of vertical transmission from mother to infant, but the risk is really reasonably low. And I would finally add that we've got 3 psychiatrists working with us at Roma Street Clinic, and all of them are now prescribing direct-acting agents. So I'm delighted to hear about metabolic monitoring. Perhaps we need to just leave a little gap for consideration of Hep C risk factors and appropriate interventions. Thanks very much.
Thank you, Jeremy. A lightning tour of a fantastic treatment. Have we got questions for Jeremy? I have one. What's the risk of reinfection? Is this a lifetime cure, or what happens when you go back to your old habits?
Oh, that's a great question, John. And the response is that unless you're seeing reinfection, you're not treating the right patient group. So we're trying to target the high-risk patients who are the active injectors, and so it would almost be expected that they may get reinfected. We had a professor from France visiting for a talk a couple of years ago. He said that he had provided 7 courses of treatment to one patient. That was the record because of repeated reinfection. So I know there's kind of developed almost a complacency in the HIV world that we've got such good medications for HIV that people may drop their guard somewhat. So I think treatment needs to be accompanied by good education about safe injecting practices. Nevertheless, remember, our goal is to eliminate transmission and undiagnosed cases. So those who are actively injecting after treatment, they should be screened every year for an RNA for Hep C and retreated if appropriate, because that's the only way we're going to really get on top of the spread.
Thanks for having me. I'm really passionate about diet and exercise in people with mental illness. Dan and Sally will know that the level of my sacrifice. I had to give up going to a ballet class today to give this presentation. So I'm really happy to be here. I've just really got a few slides that I want to fly through to get to the practical part of what we can do as clinicians and as service. The summary of this slide is that sort of exercise works for people with mental illness, but it doesn't make you lose weight on its own. It's really important to remember that. We really need dietitians for that. Oh, sorry, it's not letting me. So we know that people with severe mental illness have really poor diets, often high inflammatory index. It's essentially a sort of Western diet with processed food. And there is evidence of successful programs that will help people lose weight, but these programs all had dietitians involved and have had a higher number of actual dietary intervention sessions. So just offering a couple of sessions doesn't work. There's also a little bit of emerging evidence around the improvement of people's mood through use of diet, and Felice Jacker did the Mediterranean diet, which some people would have heard of. You know, we were talking earlier with Brett about, is it our role? And I like to show this slide, which is just how many guidelines there are that say it is our role as psychiatrists and mental health clinicians to address physical activity and diet for people with severe mental illness, including the college guidelines, very specific. What can we do? This is the summary of what clinicians can really do. So to start off with, it's really important to just screen for diet and physical activity. This is a nice question, the PABS question, that's been tested and showed to have a correlation with metabolic syndrome, which is really just asking about how much physical activity you do. You can just ask a person, but this is a nice question that's been tested in people with schizophrenia and bipolar. There are some screening tools as well, but I think for clinicians, just actually asking how much people do highlights the salience, and the same for diet. There's this move in the UK called Make Every Conversation Count, which is about making every contact you have where it's appropriate to inquire about diet and exercise, and also about drug use and other physical health considerations where you're able to do. It's sort of beyond the scope of going into all the detail there, but this is sort of considered the 5 A's of behaviour change. I think I like this slide because it's about small change, and people often think, well, if you aren't a dietitian, then you can't do anything, or if you aren't an exercise physiologist or a physiotherapist, that you can't offer anything. But actually, a colleague of Dan and mine, Simon Rosenbaum's, really promotes this idea that actually the population stands to benefit the most from making the most inactive more active, rather than taking people who are already doing a little bit and making them do more. Actually, where we really need to put our efforts is in making the most sedentary increase their activity levels. So in the service I'm in, we spend a lot of time just getting people out of bed and getting them to play ping pong or play at the pool table, or even just standing up and going for a walk. And that actually, from a research point of view, that actually has an impact on population health. The other point is that it's the amount of physical activity you're doing rather than the intensity. So low intensity activity is actually, sort of recreational walking is helpful. And these are slides here of just some little dietary activities we did with some of my patients, where we actually showed them how much sugar was in the energy drinks and the sport drinks that are so commonly consumed by people with severe mental illness. And that was just such a simple exercise that took us 1 hour to do, and people were pretty astounded. So this touches on that idea that we were talking earlier on about therapeutic nihilism, which is that, psychiatrists and mental health clinicians believe that people can't change their lifestyle. And I've actually quoted your paper, Brett, here, which I really like, which is that qualitative study looking at some of the quotes from psychiatrists about and registrars about therapeutic nihilism. If you have someone who's fat and unmotivated, there's no point. You can advise all you like, nothing's going to change. And psychiatrists have to be realistic. Unfortunately, we can't, change people's exercise regimes, etc. But in fact, the participation rates of people with severe mental illness is actually comparable to those in the general population across brief trials, and that's because most of the exercise trials are brief, and that the participation rates for physical activity are actually similar to those of psychological therapies. So I think we need to really start addressing this therapeutic nihilism. I think one of the things we can do as clinicians is support referrals to the experts. it's not enough just to say to someone with a severe mental illness, you should see an exercise physiologist. We actually have to help them to go to the GP and to get the referral, and just follow through with that. Or the other thing that we've been really successful with recently is actually in NDIS packages, building in exercise physiology and dietitian sessions under the capacity building arm of the NDIS package. I mean, not every person's going to have a package that can support that, but many people do. It's just that we as clinicians don't know to actually ask for that. And it is really, really fantastic when you get regular sessions built in. And I think we can harness the support of our support workers, of family and other team members to make these referrals happen. And also to consider community program referrals, which I'll talk about in a minute. We touched on this earlier on, which is accessing training in lifestyle therapy. So this is a slide for doctors, but it could be for mental health professionals. And so this was a nice paper talking a couple of years ago about the lack of training of doctors in general, not just psychiatrists, in lifestyle training, and how we need to address that. And so there's a big push around the world to actually train medical students. I talked earlier about how we just conducted physical activity training for the first time in Queensland for the trainees, which went really well a couple of weeks ago. But there is also this really nice module online for psychiatrists that can access physical activity training. There's not one for diet, there should be. But I think there needs to be more of these things available for mental health clinicians. At a service level, what can we do? I think implementing programs within mental health settings can't be the only thing we do, because not all services have got the space or the resources to do it, but that is something that many services can do. And this photo here, these two photos, that was actually one big room, and we cut it in half with a divider, and we made half a small gym and the other half there is the conference room. That took a lot of pushing on my part, but it's been really successful, and we just a little bit of sort of juggling of when we do our meetings and when the gym's used. And now we have a functioning gym, which over time I've been able to get small amounts of money to sort of increase activity, resources and exercise equipment. But I'm not the only person to do this. Lots of other services have started doing this. The early psychosis team, Victoria Gore-Jones has done this. Down the Keeping the Body in Mind, they've got similar photos. So it's just about actually having people to promote this. We also delivered a student-led program and had relationship with the University of Queensland and QUT to get exercise physiology and dietitian students. And that's been really, really successful, and also very small amount of money. We did need an EP to be able to supervise the students, but the dietitian students come with their own supervisor, so that's been free for us. And that little picture down the bottom there is one of the beautiful resources that one of my master's dietitian students developed, a whole series of really well set out kind of recipes for people with severe mental illness. The other thing you can do, and many teams already do this, Dan's team's got this, walking group, swimming group, is you have a champion within your team. And we identify a champion in our team at Cooper ECU for smoking cessation, for physical activity, etc. That's just a little bit of information about the student practicum placements, that you can really do a lot in a small space. That's just our courtyard there. But, a lot of services have got the capacity. They just need to sort of think about it and think outside the box. At a service level, I think it's really important that we do advocate for resources. And so that's been a big thing at Metro South, that we have advocated for exercise physiology and physiotherapy and dietitian time. And we've been successful at getting 2 permanent dietitian and exercise physiologists at an HB4 level. That's one of our previous EPs there, Steve, with some of the residents of the CCU. I think the other thing is to strengthen community pathways. So Justin Chapman's a friend of mine. He runs the Healthy Bodies, Healthy Minds program, which is NDIS funded. At the moment, it's just functioning Rebar up in Cairns, but it has been all over Queensland, and he's got a plan to kind of get more funding to be able to have people access this program across Australia, which is really exciting. And then I think we talked earlier about providing leadership. And I think, people like Jackie Curtis, who was really sort of, and Brett Emerson, some of the psychiatrists in Australia that really highlighted the importance of physical health, and Dan Siskind. And then in our service, Jeff Lau has been really leading this physical health framework, where we're developing this really detailed framework about how to train staff, but also the sort of clinics we're setting up and how we want to run them, and how we want to implement new service sort of initiatives, and we've got a working group that works on that. And then Jeanette Sewell, as part of that, has actually been leading a physical health course online that we're developing, where we'll have 3 levels. We'll have the foundation level, which is for sort of students and people who aren't health practitioners. The practice informed level is for allied health clinicians, and then there'll be a kind of a more sophisticated level for people who are actually going to train the trainers. And so that'll be a sort of an online course. It's about to go live, and we will be looking at being able to disseminate this to other services. And then finally, it's really important to try and disseminate research and evaluation. So Oscar Lederman led a paper that Dan and I are involved in around embedding exercise interventions in mental health care. And there's some really good tips there about suggestions about how you can do that successfully. And then we also published these tiny little studies that we did at the CCU, but it was really helpful in being able to share with other people what was successful. And then there are lots of little service-led initiatives that are happening around Australia, but we're not actually getting to see what's successful about those initiatives. And I think we really need to try and share successful implemented programs. And my last slide, there's some resources for people to think about. There's that latest David Taylor Maudsley guidelines and a whole heap of other online resources that people can look at for upskilling and training.